Hey everyone, I am so excited to be here today with Dr. Riestenberg. She is an infertility specialist with the Reproductive Partners Group, and she's kind of here to answer some of those questions that a lot of people might have after IVF. So let's dive in. Dr. Riestenberg, we are so happy that you are here with us today.
Yeah, thank you so much, Ashley. Really excited to be here and help answer some common questions that do affect a lot of our patients, definitely. And happy to be here with this little one as well.
Thank you. Well, this is Miss Kennedy, and she is just about 9 months old. And it was actually an IVF baby. We did the embryo retrieval, or we did the egg retrieval, and then the embryo transplant. And, I think that maybe one of the most common questions that I had, and maybe other people can agree, is after you have your first baby, if you are, a mom that conceived through IVF, what does your timeline kind of look like when it comes to the second?
So great question. And the answer is that it depends. So if you're someone who did IVF because of a true infertility diagnosis, then oftentimes it's appropriate to go back to your fertility specialist when you're ready to start trying to conceive the second pregnancy, because the likelihood is that whatever factors were at play making it more difficult to conceive the first time probably are still present and maybe even playing more of a factor the second time around. So, I know you're familiar with the fact that as women, we're born with all the eggs we're ever going to have. And those eggs decrease in quantity and quality as we get older. So that's one of the major factors that makes it more difficult for women to get pregnant as we get older. And obviously with time and having a pregnancy and then the time that it takes for breastfeeding and then to come back and be ready to have the second baby, it can make it more challenging. So I encourage earlier rather than later, just getting the information and talking to your doctor. They'll be able to really recommend whether you should try on your own or whether it's better just to go ahead and get some help right away.
Okay, so there's kind of not necessarily a one size fits all. It's almost a unique diagnosis per each person.
I would say so. I guess in general, for patients who have had to go through IVF, for the first baby, I wouldn't waste a lot of time after, when you're ready to try for the second baby. I wouldn't waste a lot of time trying on your own, primarily just because it's likely to be more challenging the second time around than it was the first time around. Now, it's not always true. There's certainly many people, we know anecdotally that once a patient gets pregnant, having to go through IVF the first time, some people absolutely get pleasantly surprised and get pregnant easily, naturally with the second one. But in general, I think it's better to get the information sooner rather than later. Go back to your fertility specialist and ask them, is it appropriate for me to try on my own for 1 to 3 months, or should I really get into treatment right away?
Okay. And is there like a general timeline? Is it best to wait a year? Is it best to wait 16 months? Is it best to wait 9 months? What is the time frame?
So for patients who have a vaginal delivery, it's the interpregnancy interval can be, as short from basically time of delivery to trying to conceive again can be, 6 to 9 months. Obviously, you have to kind of be done breastfeeding in order for the natural cycle to resume and for ovulation to occur. Whereas for patients who have a C-section, generally we recommend waiting 12 to 18 months. And some of that depends on, the C-section itself. But definitely that's something to ask your OBGYN or the person who delivered you what their recommendations are. There has been more recent, data though, looking into patients who have had infertility with their first pregnancy, and do they really need to wait that longer period of time in between pregnancies? And the more recent data is actually showing that we don't think waiting 18 months is necessary. And so we shorten that down to 12 months a lot of the time. There was a good study looking at pregnancy outcomes in women who do a second embryo transfer for their second pregnancy, and showed that, really you have very good pregnancy outcomes around the 12-month mark. So, and time's a factor. So, that's kind of the long answer. The short answer is definitely ask your doctor specifically about your particular situation.
Absolutely. So, I know that with the embryo transfer, you can, if you successfully retrieved multiple embryos from, your first round, can you transfer those, or do you usually recommend doing another retrieval?
Absolutely. So the ideal situation, for a patient who's coming to me for IVF for their first baby, and they say, hey, we really want to have 2 children ideally, or 3 children. I talk to them oftentimes about embryo banking, meaning getting more embryos in storage than you need for the first child, knowing that, you'll benefit from having those in the freezer for baby number 2 or 3. So ideally, I'll tell patients, if you want 2 children, it'd be wonderful if we could get 3 embryos, chromosomally tested normal embryos, and transfer the first one, hopefully get you pregnant, and then have 2 for down the road for baby number 2. So absolutely, if the patients have embryos available in the freezer from a first IVF cycle, the first thing we would do is try to get them pregnant with those frozen embryos.
Okay. Now, if you're using the frozen embryos, this is probably a silly question, and I think I know the answer to this, but I have to ask it anyways. Do you still have to go through the injections, up until that first trimester?
So great question. And that also depends a little bit. So you don't have to do the IVF process with the injections, but we do have to prepare the uterus and put the embryo back and support that pregnancy with hormones. Now, that can be done in different ways. Most clinics these days do primarily what's called programmed or medicated embryo transfers, which means that you're given estrogen either orally or through a patch or through an injection. And then you're given progesterone, typically through an intramuscular injection, but sometimes via a vaginal suppository. And that medication does have to be continued until towards the end of the first trimester, because we're really replacing the hormones that your body would be making naturally if you had ovulated. However, in some patients, we do what's called a natural embryo transfer, where the patient does grow a follicle of their own. They ovulate on their own, and therefore they're producing their own estrogen and progesterone. So in those patients, sometimes we don't have to give them any medication, or just support with vaginal progesterone alone.
So in that case, you would just monitor her cycle. When the follicle is present is when you would transfer the embryo.
So you can do basically either monitor them during their natural cycle. We're going to watch as your follicle grows large, and then oftentimes we'll trigger ovulation with a small injection in the abdomen that triggers release of the egg. And then after that occurs, we do the embryo transfer roughly 6 days later. So we're actually taking advantage of the body's own endogenous hormones that way.
That's really neat. Now, just kind of out of curiosity, is there any chance that somebody could end up getting pregnant with twins if they did that?
That's a great question. And the answer is yes. So if you do the natural embryo transfer cycle method and you have intercourse, then you have the chance of that the egg that you're ovulating being fertilized and implanting, as well as the one that you transfer. Yes, absolutely, that can happen.
Well, this is really interesting to me, because I think that, when I went in for my first round of IVF, and there's a lot of women, we almost are kind of like have our hearts set on like, okay, I got to do the IVF. Like, I've tried a lot of different things. It didn't work out. I don't want to risk this not working out. Let's just go all in. Yeah. But I know personally, with number 2 kind of potentially being on the horizon, I'm like, okay, that was great and all, we accomplished what we wanted, but if there's almost any other alternative, I'd be interested in, seeing what that is. So, for somebody that might have had issues with infertility, but maybe not, hardline issues that would prevent you from getting pregnant some other way. Maybe it was just you struggled for a long time and you didn't want to wait any longer. Are there other alternatives? For example, what you had mentioned, where you can stimulate the follicle and then try to naturally conceive. Is there anything kind of in that gray area?
Yeah, there absolutely is. So I would say that for patients in that kind of situation where they're coming back for baby number 2, and maybe we don't have any embryos in the freezer and they'd like to avoid having to do IVF again, the 2 best options are likely to be either ovulation induction with an oral medication like Clomid or Femara or Letrozole, combined with insemination. or doing injectable medications to try to grow multiple follicles and combining that with insemination. So those are kind of the two other fertility treatments that are available. And depending on the patient's age and infertility diagnosis, that might be a very reasonable alternative.
So if someone was interested in doing the ovulation induction, how much time do they need to set aside? How many visits are they going to the doctor? Could you just walk us through that a little bit, maybe?
Yeah, absolutely. So these are often first-line treatment options for patients who come in with unexplained infertility, and often we'll kind of go stepwise through these and then get to IVF, but certainly some people go in the opposite direction and try these after doing IVF. These are treatments that basically take one menstrual cycle to accomplish, and it all starts with the first day of the menstrual cycle. So a patient will typically call in and say, I just had my period start. We'll bring them in between the second, third, fourth, or fifth day of their cycle, with day one being the first day of full flow. We check in, then we look at the ovaries, make sure that there aren't any cysts growing, and then typically start the patient on medication, either oral medication, which is Clomid or letrozole, or an injectable medication, typically Follistim or Gonal-f, similar to, it's the same as one of the medications you might be familiar with that we use in IVF. So we can use that as slightly lower dose. And with the Clomid, with the oral medications, our goal is really to get you to grow 1 to 3 follicles typically. So that means releasing 1 to 3 eggs in a cycle. So you would take that oral medication for 5 days, and then we bring you back about a little bit before halfway through your cycle in order to monitor and see how many follicles are growing in response to the medication. Then typically we'll tell you to start checking for ovulation with your home ovulation predictor kits. You call when you get a positive on the kit, and then the following day we bring you in for insemination. So in those cycles for patients with unexplained infertility, the chance of success is roughly 5 to 8% on average. And the chance of twins is usually around 5% with that kind of treatment. So each of those cycles takes about 1 month. And we recommend that treatment for up to 3 cycles typically, because the majority of patients who are going to get pregnant with that kind of treatment get pregnant within the first 3 cycles. I think it's really important for all patients to understand that it's appropriate to seek a fertility assessment if you're under 35 and have been trying for 12 months or more, or over 35 and have been trying for 6 months or more. Or if you have any condition or medical diagnosis that would make it more difficult for you to get pregnant, it can be appropriate to come in even sooner than that. So if you know that you have endometriosis, if you know that you have polycystic ovary syndrome, if you know that you've had surgery on your ovaries before, or your abdomen and pelvis, and might be at risk for having blocked fallopian tubes, come in and get the evaluation. I think knowledge is powerful, and I think that just having that knowledge about your body is the most powerful thing you can do to empower yourself to, not waste your time. As that applies to patients after IVF, coming back for baby number 2, I would, kind of similar to what I said earlier, really encourage patients not to spend a long time trying on their own. Not necessarily that they have to do IVF again, or even that treatment immediately is the right thing, but come back, get things assessed, check in with your doctor, and make a strategic plan for how to move forward.
Thank you for joining me and getting this conversation going. And thank you so much for your time.
You're welcome. My pleasure. Thanks for having me.